dear members of the board of the university, dear members of the executive board of the UMCG, dear guests, and dear colleagues, of course. It is my pleasure to welcome you to this public meeting of the Senate of the University of Groningen. This afternoon, we are attending the inaugural lecture of Dr. Mierau, appointed Professor of Public Health Economics at the Faculty of Economics and Business. An inaugural lecture commemorates the newly appointed professor's official acceptance of the chair. Preceding the lecture, a colleague of the newly appointed professor is asked to introduce the professor by means of a laudation, offering us a glimpse of the professor's life and career. I call upon Professor Buskens, Professor of Medical Technology Assessment at the Faculty of Medical Sciences, to introduce our new colleague and ask Professor Mierau to subsequently present his inaugural lecture.
Het is mij een eer en een genoegen om Jochen te mogen introduceren. Hij heeft me dat persoonlijk gevraagd en ik was zeer vereerd en ik stel dat ook zeer op prijs om dit te kunnen uitspreken. En ik deel voor de mensen die in het zwart hier zitten een deel van het verhaal wat u al eerder hebt gehoord, maar voor de rest van de zaal ga ik er toch uitgebreid bij stilstaan bij hoe we Jochen kennen en hebben leren kennen. Wij kennen hem allemaal als hoogleraar economie van de volksgezondheid. Na zijn promotie in 2011 volgde wat je wel een bliksemcarrière zou mogen noemen. Een tenure track mondde in 2015 uit in de benoeming tot universitair hoofddocent. En in die paar jaar tijd maakte hij een switch van economische modellen naar modellen van en over gezondheid. Nog maar enkele jaren later legde Jochen de fundamenten voor Aletta Jacobs School of Public Health, waarvan hij in 2018 de wetenschappelijk directeur wordt. Maatschappelijke impact verzekerd en een bevestiging van zijn vele talenten. Een jaar later volgde de benoeming tot hoogleraar en na weer een academische oogwenk, zou je kunnen zeggen, volgde voor Jochen in 2022 alweer de volgende stap in de wereld van onderzoek en zorg voor gezondheid en epidemiologie. Hij werd wetenschappelijk directeur van livelihoods, een groot 3-generatie cohortonderzoek in Noord-Nederland. Zijn onderzoek richt zich daarbij op gezondheidsverschillen tussen, maar ook binnen groepen. Bijvoorbeeld gekenmerkt door regio, sociale economische positie, opleidingsniveau en inkomen. Veel van zijn werk gaat over de mentale gezondheid gedurende de levensloop. En de impact van economische omstandigheden op de volksgezondheid. Op die manier heeft Jochen zich gewijd aan het verbeteren van de volksgezondheid in Nederland. Maar er is nog meer te noemen. Tijdens de coronapandemie verwierf hij landelijke bekendheid door zijn regelmatige optredens in de media en deelname aan adviescommissies. Hij opende daarmee wederom allerlei deuren. En al snel werd hij een veelgevraagd spreker op radio, televisie en in podcasts. Met zijn heldere analyses en wetenschappelijk onderbouwde adviezen heeft hij een breed publiek weten te bereiken. Zijn boodschap was altijd verhelderend, toegankelijk en gericht op het verbeteren van een gezondere samenleving. Jochen schult het niet om daarbij boute standpunten in te nemen. Stel stelt hij dat door gezondheidsproblemen te voorkomen de druk op de zorg zal verminderen en op lange termijn ook kosten bespaard kunnen worden. Beleid om dit te bereiken dient uiteraard gestoeld zijn op evidentie, ofwel gebaseerd op data en onafhankelijk wetenschappelijk onderzoek in plaats van dogma en electoraal goed verkopende one-liners. En tot slot steekt hij niet onder stoelen of banken dat onze wetgever zich best met een wet en dus juridisch afdwingbaar bepaalde gezondheidsambities mag opleggen. Kortom, Jochen heeft een duidelijke visie, ambities en ontegenschappelijke leiderschapskwaliteiten die velen in de schaduw stellen. Het zal dan ook niemand verbazen dat het in het openbaar aanvaarden van het inmiddels niet meer zo heel jonge nieuwe ambt van deze hoogleraar nog maar het begin is van een glansrijke en invloedrijk vervolg. We gaan het meemaken. Maar wie is nu eigenlijk Jochen en hebben we, als we hem iets beter leren kennen, een verklaring voor zijn drive? Zijn wieg stond in 1983 in Jena, in de Duitse Democratische Republiek. Er volgde een verhuizing naar Berlijn, Oost-Berlijn wel te verstaan. En het gezin, inclusief zijn grootouders, het gezin waar Jochen in opgroeide, bood een academisch milieu dat voorzag in de nodige culturele bagage. Als 6-jarige ziet hij de muur vallen tussen Oost en West. Dat is een life-changing event. Dat heeft hem ervan doordrongen dat het heel veel uitmaakt waar je wieg staat. De verschillen tussen Oost en West bleken namelijk heel groot. En niet altijd voordelig uit te pakken voor de mensen uit voormalig Oost, ook al was iedereen vanaf dat moment op papier Duits. Deze omstandigheden maakten dat Jochens vader in 1991 de kans om in Groningen promotieonderzoek te gaan doen aangreep. Het gezin Mierau verhuisde naar Nederland. En dan kom je dus als voormalig Oost-Duits joch van een jaar of 8, 9 in Bijhem te wonen. Dan spreek je de taal nog niet en mag je niet die nieuwe vriendjes maken. Nou, al knikkerend leert Jochen Nederlands, heb ik van goede bronnen vernomen, en de waarde van de verschillende kleuren en formaten van die glazen bolletjes kennen. Hij vergaart naar verluidt aanzien, vermogen in de vorm van knikkers en inzicht in de economie daarvan. De econoom is al geboren. Het integreren gaat goed en in die tijd maakt Jochen veel vrienden voor het leven. De middelbare school staat vervolgens in Haren. En dat roept herinneringen op aan de grote verschillen in de samenleving. Rijke luiskindjes uit Haren, met hun vele voor hen vanzelfsprekende privileges, verschillen nogal van zijn buurtgenoten in Bijhem. In die tijd wordt bij wijze van spreken de socioloog en de antropoloog geboren, want hij ziet veel verschillen. Net als iedere puber zijn er vervolgens weliswaar enkele strubbelingen, maar een fantastisch stel hersens. Aansprekende voorbeelden in de familie, dus toch die wieg waar we het zojuist over hebben gehad, en een gezonde geldingsdrang en een intussen verkregen maatschappelijke ambitie maken dat een academische studie en carrière volgen. The rest is history, zou je kunnen zeggen, maar ik ben nog niet klaar. Er is nog meer. Als student wilde hij de wereld leren kennen en dat kostte geld. Dat geld wordt als pizzacourier op de brommer met een zekere doodsverachting bijeengescheurd. Daardoor krijg je belangrijke inzichten. Groningen kent hij als zijn broekzak. Hij zag en ondervond letterlijk per wijk de sociaal-economische gezondheidsverschillen. En last but not least, je ziet in dat een motor als vervoermiddel voor een roekeloze rijder misschien niet zo'n goed idee is. Zelfinzicht en lijfsbehoud. Tot slot dan, Jochen als mens, collega, vriend en familyman. En ik hou het bij steekwoorden. Oprecht, geïnteresseerd, geïnformeerd. Ongekende dossier- en feitenkennis. Bout. Creatief, ervaringsdeskundige, hongerig en vrijgevig. De bos. En dan heb ik het over Bruce Springsteen. Nobody wins unless everybody wins. En niet onbelangrijk, geliefd. The world is your stage, Jochen. Maar in Groningen hebben we je hard nodig.
Madam Rector, members of the board of the university, dear guests. Eric, thank you very much for your very kind words. I remember very well your enthusiastic roadshow 10 years ago to show how important healthy aging is not just for the medical faculty, but for the entire university. While the medical field is sometimes closed and protective, you were very welcoming and helped me over the threshold into the field. Our collaboration over the years has brought many adventures, for which I'm really very grateful. Many more people have helped me to get here, but you will excuse me if I highlight only 3. Viola, Aurora, and Jacopo, without you I would not be able to stand here. Through joy and stress, ups and downs, you're always there. Regardless of any success that I may or may not have, my greatest joy is to be part of our family. Aurora and Jacopo, it's a joy to see you becoming bigger, stronger, and more independent. And Viola, you're my constant source of inspiration in all aspects of life. Ogni giorno con te è un regalo. For all of you here today, if you find anything that I say clear, it's because Viola helped me in creating this lecture. Just like Schelto and my brother, thanks to both of you, all errors are, of course, my own. Dear guests, it is often said that health has an intrinsic, inalienable value. I will not attempt to challenge that notion. What I will do is offer a broader perspective, one that views health through an economic lens. I will argue that health is a crucial factor for economic development. Yet economic development can also impede health. The central objective of health policy is therefore to overcome any contradictions between health and economic development. If we succeed in doing so, protection and promotion of health will no longer feel like an uphill battle. It will become common sense policy. Health is a fundamental factor of production. Regardless of how well educated we are or how advanced our technology is, we can only be productive if we are healthy. But health is not just crucial for commercial activity. Every aspect of societal development requires us to be healthy enough to participate. A sports club depends on healthy volunteers. And informal care can only be delivered if family, friends, and neighbors are sufficiently healthy. In this sense, health is the most important resource that we have as individuals and as society. Without health, society comes to a halt, just as we experienced during the COVID-19 pandemic. While it's hard to quantify how much economic growth can be attributed to health, it is clear that an unhealthy workforce reduces our economic potential. Consider obesity. It is on track to beat smoking as the most important avoidable risk factor. Obesity contributes to a wide range of health problems, from the well-known link with type 2 diabetes and its complications such as kidney disease and necrosis, to its increasingly well-established relationship with various cancers. Over the past half century, obesity rates soared worldwide. In 1980, only 5% of the Dutch population were considered obese. Today, it has tripled to 15%. In the United States, it has skyrocketed to 40%. The World Health Organization now refers to it as an epidemic. But as we will explore later, this epidemic was not caused naturally. It is man-made. It is an outcome of our economic process. The impact of obesity poses a substantial threat to our economy. The Organization for Economic Cooperation and Development estimates that obesity stands to claim as many as 92 million lives in the coming decades, and that 8.4% of healthcare budgets will be absorbed by costs associated with overweight and obesity. While the economic burden of such large, avoidable healthcare expenditures is already significant, the main impact of bad health is due to lost economic activity. Unhealthy people are more likely to be unemployed. When employed, are more prone to disease, leading to absenteeism and presenteeism. For obesity and overweight alone, the OECD estimates a potential loss of 3.3% of economic output. In other words, we are suffering from an obesity recession. Preventing obesity doesn't only make health sense. It is sound economic policy. Bram Woutersen, Sander Boksebelt, and I show that stabilizing obesity rates in the Netherlands at their current level could boost economic output by €2 billion. Just imagine the economic boom if we succeed in turning the obesity tide. While population health measures like obesity rates provide valuable insights, understanding how health as a production factor can be enhanced requires us to look beneath the surface at health differences. Among the many factors for differences, two stand out: age, and social class. Most conditions show a clear increase in prevalence with age. Cancer and cardiovascular disease, for example, share one important risk factor: aging. In fact, age is such an important risk factor that preventing birthdays may well be the most effective public health intervention. Yet we celebrate them. Mental health problems, however, have a markedly different pattern. They tend to develop much earlier in life and exhibit patterns that do not display the typical increase with age. Some scholars have suggested that mental health is at its worst at midlife, but Hermine Dijk and I have demonstrated this to be a methodological artifact. The true trajectory remains unclear, a question we hope to address together with Rob Alessi soon. Let's be clear, the atypical life cycle pattern of mental health is not just a puzzle for statistical connoisseurs. It shapes the impact that mental health has on individuals and society. Unlike cancers and cardiovascular disease, which mainly affect individuals who are near or after retirement, mental health problems affect people over their entire life cycle. According to the OECD, the cost of mental health problems run to 3.3% of economic output, driven largely by lower economic activity rather than healthcare expenditures. Viewing health as a production factor, therefore, implies a much more prominent focus on prevention and treatment of mental health problems. Looking beyond age, social class is a critical determinant of health disparities. Engels already observed the dire state of the working class in England in the mid-19th century. He argued that the health disadvantage of the working class was not due to personal failure, but that the circumstances they were exposed to at home and in society amounted to nothing less than social murder. In contrast to actual murder, social murder appears to be a perpetratorless crime. No one was prosecuted for workers' lives that were nasty, brutish, and short. What was true then remains true today. While individuals with a lower education in the Netherlands live 5 years shorter than people with a higher education and 14 years shorter in good health, no one has been prosecuted for this loss of life and well-being. We owe to Michael Marmot much of our understanding of health differences across social classes, especially his seminal work from the 1970s, which provided two key insights. The first is that health disparities do not just affect the least advantaged groups. Instead, there's a gradient running from the least to the most advantaged groups, and each successive increase on the social ladder is associated with better health. The second is that health disparities across social classes are not fully explained by common health threats such as smoking and poor diets. Social class in and of itself is a determinant of health. Building on Marmot's work, Viola Angelini, Dan Howden, and I have been able to extend these insights across the life cycle to show that even if you climb the social ladder, your childhood social position is a crucial factor in shaping your physical and mental health in late adulthood. Moreover, with Laust Mortensen, Anna Vera Paulsen, and Frederick Christensen, we have established that the class pattern in health is not limited to a selected number of diseases. Instead, for virtually all communicable and non-communicable diseases, a higher socioeconomic position is associated with lower prevalence of disease. If you've been paying attention, you may have noticed that while this was billed as a lecture on public health economics, I've been focused on disease. Maybe I should have become a professor of disease economics instead. Joking aside, much of health research actually deals with disease instead of health. Studying disease is facilitated by the rise of modern registry data, which meticulously track disease. However, the purpose behind the registries is not to facilitate research, but to enable reimbursement systems. As treatment of disease is reimbursed, but maintaining health isn't, the registries end up covering a limited part of human health, the sick part. To actually engage in health research, we need to rely on other sources. Prospective cohort studies and biobanks, such as Lifelines, but also the UK Biobank and the Tohoku Medical Megabank, play a crucial role here. Unlike registries, their starting point is not disease, but health. Viewing health and not disease is the unique strength of Lifelines, one that the University of Groningen, the University Medical Center Groningen, the Northern Netherlands and the Ministry of Health can be proud of supporting, but also have a responsibility for maintaining. By collecting data and materials straight from the participants, we are able to provide health assessments for nearly 10% of the population every 5 years. Academic research hardly ever gets more tangible than this. In Lifelines, we have been following the health of the Northern Netherlands population for almost 2 decades. By collecting data from biosamples, functional measurements and questionnaires, and linking these with information on environmental exposures and socioeconomic conditions, we can trace health and disease as well as their determinants over the life cycle. To understand how health develops over the life cycle, consider this graph. I promise it's the only one today. The graph displays the number of biomarkers, such as blood sugar levels and cholesterol, which are commonly associated with various diseases later in life, that are above a value that would make your GP worry. The green part shows the share of individuals who don't have a single biomarker that upsets GPs. While this group becomes smaller over time, even at very high ages, there are quite some people who, based on their biomarkers, are healthy. If we want to understand healthy aging, this is the most interesting group. Yet if we rely on disease-based registry data, we would never be able to identify them. These data are therefore a treasure trove to anyone interested in healthy aging. In ongoing work with Laura Viluma, Ailun Shui, and Gerard van den Berg, we've already been able to use these data to establish that biomarkers show socioeconomic disparities early in life. With other words, even before diseases such as type 2 diabetes manifest themselves, there is a difference in the early signs of these diseases across socioeconomic groups. This means that we should not wait for disease to set in, but focus on prevention and early detection in order to combat health disparities. Just as I have done now, we often emphasize the health differences between social classes. But as Marmot already observed, poverty is not destiny. Many poor people are actually quite healthy. And I would add to that, that affluence is also not destiny. Many wealthy people are actually quite unhealthy and have poor health behavior. Collaborating with Ruud Koning, Erik Buskens and Willem de Boer, and using Dutch health insurance data, we have created an important nuance in looking at health disparities. While our research showed the common pattern that low-income neighborhoods tend to have higher healthcare expenditures, our research also revealed large differences in healthcare expenditures across neighborhoods with the same income level. With other words, quite a number of poorer neighborhoods actually have lower healthcare expenditures than richer neighborhoods, and there are quite some richer neighborhoods who have much higher healthcare expenditures than poorer neighborhoods. This means that we can potentially realize substantial health and economic benefits without adjusting the underlying socioeconomic differences. Analysis with Louise Dekker, Gea Navis, Jinji Zhu, and Stefan Bakker have shown that the key to realizing these benefits lie in lowering smoking rates, increasing physical activity, and taking into account how individual and neighborhood deprivation interact with each other. And ongoing research is highlighting that loneliness is a major contributor to health differences among individuals with the same economic position. These insights beg to change the question from why are poor people sick more often than rich people to why are poor people healthy? Let's look at the exception rather than the rule and see what the exception can teach us. Together with Erik Busken, Stefan Pichler, Laura Viluma, and Marianne Soares, we hope to provide better answers to this question through our EcoTip project. I hope that by now I've demonstrated that health is a crucial factor of production and that its unequal distribution acts as a drag on our economic development. Now it is time to focus on where this factor of production comes from. While we often associate health with healthcare, healthcare alone does not create health. Only 10 to 20% of health is attributable to healthcare. The rest is due to biologic and genetic factors, individual behavior, the social environment, and economic conditions. If we want to understand health, we therefore have to look beyond healthcare and focus on factors threatening health. Historically, major threats to health were like natural disasters, famines, pests, volcano outbreaks, extreme weather, earthquakes, etc. In contrast, today, in the Anthropocene era, health threats are not natural disasters, but are byproducts of our economic system, capitalism. Major threats such as smoking, poor diets, and lack of physical activity did not descend like meteorites from the sky. They've been driven by the deliberate actions of health-harming industries, polluting the air, selling tobacco, providing unhealthy food, and facilitating a sedentary lifestyle. Sitting, indeed, is the new smoking. Health-harming industries have grown to such an extent that the World Health Organization estimates that they now account for 19 million deaths annually worldwide. These industries, driven by profit motives, have become a significant force in shaping public health outcomes, with their actions posing an avoidable risk for health on a global scale. These new risk factors have been coined as the commercial determinants of health. While the focus on commercial determinants of health is a relatively recent development, in my opinion, the mechanisms behind them can best be understood by focusing on the economic logic of capitalism. Since the beginning of the Industrial Revolution, volumes have been filled about the workings of capitalism. Instead of rehashing those debates, I would like to highlight some of the main tendencies of capitalism in the hope that it will help you understand its impact on health today and its implications for modern health policy. The central goal of capitalism is the accumulation of capital. Profit, therefore, is the key objective of entrepreneurs, but the ability to make profits is limited by competition with other entrepreneurs. In other words, in order to compete with others, entrepreneurs must constantly innovate. Those who fail to innovate fall behind and are eliminated from the market. Innovation can manifest itself through product innovation or cost reduction. Product innovation has provided society with many goods that have improved health and well-being: fertilizer, sliced bread, and super soft toilet paper. And of course, the production of all these goods provides millions with their livelihoods. But the objective of innovation is not the increase of well-being. It is to survive in the competitive struggle. Hence, innovation has also brought many health-harming goods, such as alcohol, tobacco, sugar-sweetened beverages, and social media. Moreover, the other form of innovation, cost reduction, often leads to the exploitation of workers and nature. Think about pollution and poor compliance with labor laws, leading to hazardous working conditions. Exploitation is often viewed through a moral lens. However, Marx already observed that the capitalist is only capital personified. His soul is the soul of capital, but capital has one single life impulse, the tendency to create value. Exploitation is therefore not a moral failure of the individual entrepreneur. Competitive pressure drives entrepreneurs to adopt a strategy that accords with the norm of the market. While each individual entrepreneur may have a moral that forbids adopting harmful practices, that moral will melt in competitive pressure. Therefore, what we observe as the norm in the market is not the average of morals of the entrepreneurs, but the minimal norm upon which competition is played out, the law. In the absence of laws protecting labor and nature, exploitation eventually leads to the collapse of society. With workers exploited to the point of exhaustion and nature to the point of extinction, capitalism can no longer function. As we observed 15 minutes ago, regardless of how skilled workers are or how valuable machinery is, if workers are too ill to use them, society comes to a halt. I already hear you thinking, the collapse of capitalism has been prophesied since its inception, but it's only gaining momentum. True, while the tendency to collapse is inherent in capitalism, so are the countervailing powers that prevent it from collapsing. Capitalism doesn't just produce goods and services, it also produces the institutions that keep it in power. Exploitation of labor, therefore, has been met with reductions in the length of the labor day and improvement of working conditions. While we tend to remember these as victories of the labor movement, these reforms, importantly, saved capitalism from itself. Having explored the main mechanisms of capitalist dynamics in health, let's return to today's challenges. Luc Hagenaars and I argue that we see the same forces at play. Capitalism is still a great engine of innovation, but it has also not shed its exploitative feathers. However, with safer working conditions, at least in high-income countries, the exploitation of health has shifted to the consumption side. Health is now exploited through the goods and services offered on the market. Food has been engineered to the point of addiction, and inescapable marketing is constantly pushing health-harming goods and services. This is not limited to food. Tobacco firms have paved the way for the past century, and many of their practices are now being adopted by other industries. Today, tobacco, ultra-processed foods, fossil fuels, and alcohol account for 34% of all deaths worldwide. These deaths did not arise from the ill intent of shareholders. They are the consequence of the competitive struggle in which only those shareholders survive who are willing to invest in health-harming goods, regardless of the harm that it brings. Firms that choose not to play by the norms of the market are ruthlessly eliminated from economic existence. But by competing on this lower bound, capitalism is once again moving toward its collapse. Overconsumption of health-harming goods and services is making the workforce ill, with stark consequences for the labor market and the economy at large. And while previously labor was abundant, population aging has dried up the industrial reserve army, and every sick worker is an irreplaceable loss in economic activity. To engage with these capitalist dynamics of health, research needs to move toward new hypotheses. Like earlier research on capitalism dealt with the tendencies inherent in it, we should look to establish how these tendencies are affecting health today. From these tendencies, we can then derive new testable hypotheses, but for now the crucial step is to develop new questions and hypotheses. Taking the tendencies as a starting point, an important observation is that health research itself is not immune to the forces of capitalism. This has profound impact on the strategies we follow, to overcome public health challenges. I'm excited about the new project that Jan-Willem Romeijn and I are starting, in which we aim to generate a better understanding of how the profit motive inherent in capitalism affects what we know. Put more complex, capitalism has epistemological implications. Let's put it more simply, but don't lose me at the first sentence. Following Leibniz, consider the existence of many possible worlds. Out of all possible worlds, each social system reveals a particular one. Capitalism reveals the one that is profitable. Through its focus on capital accumulation, capitalism censors other possible realities. Not because it wants to suppress them, but because in capitalism only the possible realities survive that play by the norm of the market. The products on the shelves are the ones that sell. The entertainment we see is the one that attracts paying audiences. The news we read is shaped by what advertisers want. While capitalism may profess that we are free to choose, in fact, we're only free to choose among choices that are profitable. Capitalism occasionally lets through a glimpse of other possible worlds, but the dominant one is the profitable one. Now let's apply this tendency to public health research. Consider all potentially effective strategies to overcome public health problems, such as rising obesity rates. Since there are always more ideas than resources, only a limited number of the potentially effective strategies are actually proven to be effective. Ideally, these are a good reflection of the potentially effective strategies. However, because science requires resources, a bias emerges concerning which strategies receive validation. Interventions that are potentially profitable for the provider are much more likely to be researched than the ones which do not have direct profits. This concept might seem complex, so let me explain it a bit more. Today, the lion's share of health research is industry funded, by an industry that is driven by profits and competition. As a consequence, research is skewed towards interventions that generate profits. Strategies that do not deliver profits or even threaten them are much less likely to be studied. This means that out of all potentially effective strategies, we mainly see the profitable ones. Crucially, this is not solved by making agreements on intellectual property rights, nor does it arise from scientific misconduct. Even if companies adhere to the highest standard of scientific integrity and all contracts are fair, the knowledge produced is a limited sample of potential knowledge, the profitable one. This tendency provides a critical role for universities, ensuring that the proven effective interventions are a good reflection of all potentially effective interventions. This does not mean avoiding collaboration with industrial partners, but rather acknowledging the bias it creates. It means supporting interdisciplinary infrastructures, such as the Aletta Jacobs School of Public Health. It means not attaching co-finance requirements to research grants, but assuring that research is funded that has societal benefits without necessarily having a return for an individual commercial party. It also means assuring public funding for lifelines. For if we deliver biobanks and cohort studies to industry, every health problem will eventually have a pharmaceutical solution. Given this tendency and its impact on research, it is no surprise that the market's answer to the obesity pandemic is treatment and not prevention. The effectiveness of the new class of drugs is not in question, though concerns about side effects and long-term consequences remain. The point is that history has shown that public health problems are solved through prevention, not by treatment. But prevention does not have a private business model, while obesity drugs have enormous returns for shareholders. Hence, when faced with a choice between investing in prevention or treatment, investors will prefer treatment, not because of malice, but because that's how the market works. The market, however, cannot solve the public health crises it helped create. While obesity drugs may improve the health and well-being of those who take them, firms that produce ultra-processed foods, sugar-sweetened beverage, or fast food are not standing still. They're innovating to survive. First signs are arising of manufacturers developing food that is attractive even to those individuals who are using obesity drugs. In the coming years, we are likely to see an escalating arms race, ever more effective obesity drugs versus food that is engineered so that it remains attractive nonetheless. The constant adaptation is not limited to market competition. It also applies to regulation. Just as firms innovate to outcompete each other, they also innovate in response to regulation. This can be beneficial, as when soft drink manufacturers in the UK lowered the sugar content of soft drinks in response to sugar taxes, but it can also be harmful, such as the addition of homeopathic quantities of dairy to juices by Dutch producers to circumvent the same sugar taxes. Static regulation, therefore, cannot regulate dynamic markets. Over time, firms will find a way to undermine the regulation, with the consequence that they corrode the very foundations that are necessary to sustain the market and society as a whole. In sum, neither the market nor static regulation can address the public health challenges we face. We need to look further. Many of the greatest advances in health did not come from treatment. They came from the protection of health. But the protection of health threatens two business models: the health-harming industries that create the problem and the industries that benefit from treating avoidable disease. A powerful public health strategy therefore counters two strong private business models, yet creates a public benefit. But industry-funded research is unlikely to generate the evidence necessary for developing such a strategy. Making sure that these strategies are researched and developed is the alpha and omega of academia. The question is therefore how to effectively protect health in capitalist societies. Together with Brigitte Toebes, I've been working toward a new idea on health protection, one which begins with holding political actors accountable for health outcomes. Looking at major challenges over the past half century, we see that turning points came when accountability was clearly set. European public finances improved with the introduction of fiscal targets in the Stability and Growth Pact. Inflation was tamed through inflation targets, and the climate goals set out in the Paris Accords led to an increase in the policies aimed at mitigating climate change. For health, however, there is no political accountability if targets set out in various agreements are not met. A breach of targets is often met with silence. Just think about last week's report in the media that despite all policies, obesity rates in the Netherlands are still increasing. There was no emergency debate in Parliament, no cabinet crisis, nothing. Just silence. Essentially, public accountability for health outcomes acts as a counterweight to the market objective of capital accumulation. In practice, it means that we need to give the same status to the goals set out in the Sustainable Development Goals. Think about a 30% reduction in mortality from non-communicable diseases, as we do to budget and climate targets. By holding the government accountable for health outcomes and markets for capital accumulation, we can work toward a society in which public health and economic development strengthen each other. Exactly what we set out to do half an hour ago. Legally mandated health goals are not a magic bullet. Just setting them does not change anything. What it does do is break the silence when goals are not met. It means that Parliament can legitimately ask why the WHO quick buys are not fully implemented despite the state of public health. The quick buys are an extensive list of cost-effective public health interventions that provide quick results. Think about a sugar tax that depends on the amount of sugar in beverages. It would also mean that we would provide local councils with legal tools to avoid cities from becoming fat swamps. Just count the number of fast food outlets on your way out today. And it would encourage shareholder action to stop supermarkets from being merchants of disease. I'm encouraged to see that the idea of political accountability for public health has quickly caught on in the policy debate. A parliamentary majority has already called on the government to study the imposition of public health goals more closely. Various political parties have taken up public health goals in their election programs, and some of the highest advisory bodies of the government have advised it to take the goals seriously. And to my joy, last week, Minister Karremans emphasized the need for public health targets in an interview with the Volkskrant. Change is coming. Now that we have come to the end of the lecture, I hope to have extended your perspective on health and health policy. We started by recognizing that physical and mental health are crucial factors of production, ones that determine economic potential at the individual as well as the national level. Yet our economic system, driven by a need to accumulate capital, is putting health under pressure. Health disparities persist and exclude those in disadvantaged positions from economic opportunities. Market forces prioritize treatment, despite clear evidence that health gains come from prevention. Static regulation is insufficient in the dynamic market, and industry-funded research is skewing our knowledge base towards profitable solutions. To truly protect health in a capitalist society, we must counterbalance the power of the market with a societal goal to protect health. This begins with government accountability for public health outcomes. Legally mandated health goals will protect our health and save capitalism from itself. Ik heb gezegd.